issues regarding Senator Rivera's schedule. So welcome everyone. My name is Catherine Soka. I'm co-chair of PEER, Progressive East End Reformers. And I want to again welcome everybody from around the state, but I want to give a special thanks and a welcome to the legislators and the town workers who are here to find out more about the New York Health Act. We really appreciate your taking your time tonight to be with us. I ask everyone to please stay muted during the course of the program. If you have questions, you can drop them in the chat and they will be asked during the Q&A portion. So the lead sponsors for this event are Long Island Activists and PEER. Both organizations are chapters of NYPAN, New York Progressive Action Network, and we are both multi-issue grassroots organizations committed to justice and through electoral politics, working for justice rather, through electoral politics and issue-oriented engagements. Next month, we're going to have a program, actually a town hall with Assemblymember Fred Thiel on the Invest in Our New York campaign. So stay tuned for dates and information about that. So 1 year ago, almost to the day, our organizations hosted a New York Health Forum at the college when we could all actually be together in person with Dr. Martha Livingston and Dr. Cheryl Cashin. And Martha immediately, upon the beginning of the presentation, launched into a cautionary discussion of the coronavirus, what its impact could be as it was just beginning to edge its way into the northwest of our country. Her words proved prophetic and they were chilling. She ended by saying, "We are not prepared." Last night, sadly, we crossed the threshold of 500,000 deaths in our country. And so we're left to reckon with our lack of preparation and our country's dismal response to these grave dangers. So if America really needed one thing in the face of this pandemic, a single payer healthcare system would have been it. A study has recently estimated that if the country had a public health and universal healthcare infrastructure comparable to those in other high-income countries, 40% of the COVID deaths could have been avoided. 200,000 lives could have been saved. So let's just pause for a moment and reflect on those lives lost. And in that moment, let's dedicate ourselves to making the New York Health Act a reality to honor them. New York has the unique opportunity to lead the way forward for single payer. And that's why we're here tonight. Our program, the New York Health Act, it's not too good to be true, has three different sections to it. The first section is going to be a general overview. Then we're going to shift to what the act means for local governments and businesses, how it can save their budget on their budgets. And then the third prong is a section where we are going to figure out what we can do, what actions we can take going forward to pass the New York Health Act in 2021. We're honored to have a number of special guests this evening. Robert Buonaspina from Long Island Activist is now going to introduce them to you while I drop in the chat a link to a Google Doc and also the Campaign for New York Health Act petition that we want everybody to sign. So thank you again for being here. Robert, please.
Sure. Our special guest tonight is State Senator Gustavo Rivera. Senator Rivera has represented the 33rd Senate District in the Bronx since November of 2010. Since taking office, Senator Rivera has focused his efforts on addressing issues of health inequity, both legislatively and on the ground. He currently serves as the chair of the New York State Senate Health Committee, where he was the ranking member for 6 years. Gustavo was born in Santurce, I hope I pronounced that right, Puerto Rico. A proud,
Kinda.
You're going to correct me later. A proud Bronxite. He has lived in Kingsbrook Heights for almost 20 years.
Kingsbridge. Come on, bro.
Kingsbridge Heights for almost 20 years. Also with us tonight is Darius, oh boy, I should have practiced your last name again, Shahafar.
Sean Farr.
Sean Farr.
Yes.
who is the current treasurer of Albany in Albany, New York, has held that elected office since 2014. His work as city treasurer has led to researching the efforts of healthcare financing on municipal budgets and local property taxes. He has testified on this subject to the New York State Legislature. He believes strongly that single payers will result in dramatic tax and cost savings. The graduate of Bates College and Albany Law School, where he served as editor-in-chief of the Albany Law Review. We also have with us Steve Auerbach. Steve Auerbach grew up in New York City and received his MD and MPH from Columbia University, completed a residency in pediatrics at UCLA. He's a longtime member of the board of directors and executive committees of the New York Metro Area Chapter of the Physicians for a National Health Program, and the nationwide health professionals group advocating for single payer national health insurance, also known as Expanded and Improved Medicare for All, and works with the Campaign for New York Health. We also have with us Dr. Martin Livingston, who also serves on the National Board of Physicians for a National Health Program and is the chair of public health at Old Westbury. Old Westbury, and if I said something wrong there, Dr. Livingston, I'm sure you'll correct me later. The moderators of today's event are Dr. Cheryl Cashin. Dr. Cashin is a health economist specializing in the design, implementation, and evaluation of health financing policy in low and middle income countries, with a particular focus on health purchasing and providing payment for universal health coverage. She is also a managing director at Results for Development in the Global Health Practice. In that role, Dr. Cashin co-leads a portfolio of more than 20 projects and initiatives in global health systems, and she serves on R4D's executive team. And then we have Steve Cicchini, who is currently on the NYPAN executive board and a member of the Campaign for New York Health. He's also an active member of Long Island Activists and Suffolk County DSA, and he's quite knowledgeable about the ins and outs of the New York Health Act. Mr. Cicchini also works as a farm manager at Restoration Farm and Organic CSA on Long Island. Those are our guests and panelists, and we welcome you all.
Thank you.
Thank you, Robert and Catherine. I think I'll get us started. We are all reflecting on that sobering statistic and that milestone that we reached, those 500,000 fellow family members, friends, neighbors that we've lost, and the failure that is represented in that number, the failure of our healthcare system. And the New York Health Act is a realistic and feasible option on the table that we are so lucky to have. And we want to hear more about that. And Senator Rivera, as one of my healthcare heroes, I'm so happy to welcome you and ask you to start us off by just bringing everyone up to speed on the New York Health Act, just the highlights. What is covered? How would we access care? And how would we pay for it?
First of all, good evening to everybody. I'm very well dressed for you folks. It has been a full day and I have not stopped. I had the camera off because I was trying to scarf as much of my dinner as I could, because at 7 I have something else and then 7:30 I have something else. So I'm trying to see if I can do it in the middle, but I'm very glad to be here. Buona spina. Very good to see you, sir. It is Santurce, Puerto Rico. That's cool. But Kingsbridge though, Kingsbridge Heights in the Bronx. Gotta get that right. Anyway, so I will keep it short because I want to make sure that we get questions. We start with a very basic concept. Healthcare is a human right. Whether you are wealthy, whether you are poor, whether you're black, white, brown, whatever, wherever you live, if you're a human being, you will get sick. And it should be a very basic, it is a very basic notion for those of us that believe that healthcare is a human right. That means that we have to move policy to make sure that we guarantee healthcare to every single person. The New York Health Act would do that. As far as what it would cover, anything that is medically necessary. Basically, it would, including dental and vision, which is important, as well as long-term care. And we'll probably get into a whole series of conversations about folks that are resistant to it, particularly with what I refer to as the bird in the hand issue, right? The people said, we have this right now. I have been able to negotiate for this. This is the benefits that I have right now. I have this bird in the hand. Are you sure that what you're offering me is going to be better than this? First of all, yes, it is. But that bird in the hand, does it include long-term care? I'm going to guess that that's a no. So just that by itself, and I should tell you that it was advocates for years who convinced both my colleague in the assembly and I Dick Gottfried, who's sponsoring the assembly, and myself to include it just a few short years ago. Now, where it is, because I want to make sure that we get into the questions. Where it is that we're about to reintroduce it. There are some changes that we have made to it since the last version that you can see online, particularly around the situations of birthing people. There are some folks that were activists on behalf of birthing mothers who came to us and said, hey, we believe that there's some things that you can change here to make it so that it is more clear that these services are available. And we thought that some of those changes made a lot of sense. And so we are going to make those changes. But the other thing is that I am working on getting 32 of my colleagues, well, 31 of my colleagues, including myself, to commit to sponsoring the bill at its introduction. And right now I have 30, and I'm working on a few more to see if I can get 32. Now, that doesn't mean that they can't jump on afterwards, but my preference would be to introduce this bill and have 32 names right on the bill. For those of you who don't know, when a bill is first introduced, anybody who is a co-prime sponsor at its introduction, their name is actually on the text of the bill. So the bill is one that will be funded by the graduated assessment, payroll tax based on someone's ability to pay. So it is one that is more equally distributed amongst the entire population. And it would cover everybody in the same system. We're talking about, and this is something that Dick Gottfried talks about all the time, if we make sure that the system that serves the governor, that serves you, that serves me and our families, is the same one that serves a poor working class person, an undocumented person, or somebody else in the state, if it's the same system, guess what? The folks that are in power will make certain that it is a system that they defend. And it is one that we can make sure we have a higher standard for everyone. So I will just say that I'm looking forward to the work that we're going to do ahead. The last thing I will say is the last mile is always the hardest. It is up to us as a collective of advocates, of organizations, and electeds to kind of push both my colleagues to be on the bill, my colleagues who are on the bill to become not only sponsors, but become cheerleaders of it, and to convince our leadership to make sure that it's brought up to a vote, both in our House and in the Assembly, so that we can actually get it to the governor's desk. And we can certainly talk about my good friend, the governor, whenever you desire. But anyway, I want to leave it there so we can leave it open for questions. But again, I thank you for the invitation. I am going to scarf some stuff in between while you ask the questions, if you don't mind. Go ahead.
Hello?
So
Oh,
Yes.
I have a question.
Who's that?
Roger Meadows.
Identify yourself. Go ahead.
Roger Meadows. You said you.
it's
Oh,
okay.
you said you got 30 co-sponsors.
I have 30. Well, right now, not technically because the bill has not been reintroduced, but I have commitments from 30 of my colleagues. Well, 29 of my colleagues, including me, would be 30, to become sponsors, to be sponsors right when the bill is introduced.
Do you got a commitment from Thomas?
I believe that we do. He was on the bill last year, was he not?
Yes, he was. Yes, he
And
was.
he's on the bill. He's on the bill.
What about the new people upstate?
Both Senator Cooney and Senator Brook have agreed to be co-sponsors of the bill, and also Senator Reichlin Melnick. And I realize that there's a lot of these names that you folks might not recognize. We have in Rochester, we were able to flip 2 Republican seats into 2 magnificent new members up there, Jeremy Cooney and Samra Brook, and then Elijah Reichlin Melnick replaced Senator Carlucci in Rockland, and he also committed to be on the bill.
Okay. So that means Ryan is not on it then. You don't have a commitment from Ryan.
I'm working on both of them right now.
Okay. So Henchy, Ryan, and and Mannion.
Correct.
Okay. So no commitments from them yet.
Roger,
Yeah.
can I ask a question?
Sorry.
Thanks.
And I'm sorry if I'm messing with the format here. I'm not sure exactly how this.
It's all good. It is all good. One of the questions that I've.
Who's that, by the
gotten-
way? Identify yourself.
I'm Steve Cicchini from Long Island, and one of the
Okay, there you go.
questions I got from the initial sign-up sheets, people wanted to know who decides what is covered and who decides what reimbursement rates, how they're set.
Very good question. As far as what is covered, currently anything, excuse me, that's a nice hot sauce on that one. Currently anything that is covered by Medicaid is would be covered by New York Health. As far as payment is concerned, and this is an important one, the bill itself has language that does not exist anywhere else, which would say that the rates to be set, because the rates are not set in the bill itself, but it gives the authority to a board, the makeup of which is in the bill. So the board would set the rates, but the rates have to correspond to what the service actually costs to provide. So the bill itself has language that says, because right now, when you say like people, so Medicaid rates all the way down here, right? Private payers all the way up here, which is why a lot of people don't take Medicaid because the rates are so low. Medicare is a little bit higher, but still in overwhelmingly most instances, private payers are much higher. So by setting in statute that the rates to be set by the board have to correspond to the cost, to what it actually costs to provide the service, that means that we're going to equalize it. Now, I don't know exactly where it's going to be, but I can assure you places like St. Barnabas Hospital, which is in the middle of the Bronx and is a safety net hospital that serves like 90% of its people are Medicaid patients. They are obviously, the executive, the CEO there tells me like, dude, if you do this tomorrow, we'll be golden, because we don't have to deal with like the fact that we're getting underpaid for basically every single person that's walking through the door. So again, the rates are in, that language is in the bill, which exists nowhere else.
Senator Rivera, this is Cheryl Cashin. So what you call the bird in the hand issue, I call the devil you know issue. So I think it's about the same thing. I'm going to bring up another question that was posed during registration. It's a bit of a long one, so you can take another bite.
Okay.
During contract negotiations for collective bargaining units, union leadership has at times forgone larger wage increases in exchange for lower healthcare premiums. So how do the unions feel about the New York Health Act and in particular CSEA?
First of all, we have, first of all, I should say that my colleague and I, Dick Gottfried and myself, both of us are big believers in organized labor. His parents were both UF team members. I am a current member of NYHA as a part-time professor, and I have been one for most of the time that I've been in the US. Now, so we believe very strongly that working class folks would benefit from this, and that we need organized labor to be along with us. And many of unions have already signed on. Whether we're talking about 1199, 32BJ, the Nurses Association, Communication Workers of America, RWDSU, all these folks have actually become big supporters of it. Then there's the folks that are more resistant, and public employees among them. And we are working with them. So as far as CSEA has been very vociferously opposing the bill, and we continue to work in good faith with them to see if we can get to some sort of agreement. Now, the reason there, I can tell you that it is true. It is absolutely true that over the years, there has been negotiations that have occurred, and that in which workers, regardless of where you're talking about, most negotiations, if not all of them, probably come down to healthcare costs. And they have, in many instances, given up raises or other benefits to be able to keep their health benefits. That's a real thing. I do not dismiss that, neither does my colleague Dick Gottfried. What we are saying is that going forward, we want to take that off the table. Now, a union leader who has not yet signed on, and I'm not going to identify him for the sake of, hopefully he'll be able to say this on a microphone at some point relatively soon, said to me like, wait a minute, let me get this straight. You're telling me that the next time that I go to negotiate on behalf of my members, that I don't even have to talk about healthcare? And I said, that is what we want to do, yes. And they're like, sign me up. If you can tell me that, sign me up. So it is true that public employees have, on average, much better health insurance coverage than anybody else, right? And I don't deny that. But there's a couple of things that I would say. Number one, it does not include long-term care. Number two, they have a network which is limited. So the New York Health Act would have no networks. The network would be the state of New York. Even the best of plans still has a couple of, I wish I had there's a table in front of me that I made when I actually dug into this, because even the best plan provided to private teachers, for example, or to public employees in the city of New York, still has a couple of places where you still have to come out of pocket, and you still have to stay within a network to be able to do it. And you don't get to make necessarily decisions about who your doctors, whether your doctor is in the network or not, or whether the drugs that the doctor tells you that you need to take are in the formulary or not. All of these things, because of insurance companies, that's what we're trying to erase. So it's a sincere concern, and we know that that's the case. We're working with them to make sure that they come on board, and we'll continue to do so. Folks, anybody who in good faith wants to talk to us about how to make this bill better so that we can provide a higher floor for every single New Yorker, we want to work with them.
I want to ask a quick question in the chat, Senator Rivera, from Gabe Fetter. He says, the big question everybody always asks is how will we pay for it and who pays the freight? Does the plan still include a portion of payment in taxes by businesses per employee? If so, how do we counter the disincentive that can represent to their business to hire its effect on employment?
A couple of things. Number one, studies have told us that because there's going to be so much money that is saved from this system, this is a system that saves money. We can get into why that is, but it saves a whole lot of money. That money actually gets reinvested into the economy, which means more economic activity. So there are a lot of jobs that are created if we move towards this. That's number one. Number two, the payroll tax that we're talking about, as I said, is a graduated assessment, so it's based on the ability to pay. And the reality is that the same studies that have told us how much money we're going to save tell us that about 95% of New Yorkers would pay less than what they're paying now, because we will eliminate premiums, we will eliminate out-of-pocket costs, we will eliminate that thing that you give to your doctor when you go and they say you got a $10
Copay.
Thank you. Copay. Yeah. So all of these things will be eliminated. So even in the best case scenario, you're talking, and as far as businesses are concerned, we actually have plenty of businesses that have signed on in support of it because they know that a healthier workforce is a better workforce. And actually particularly for those businesses who provide healthcare to their employees, that cost also is going to be so much lower because they don't have to negotiate with insurance companies on behalf of strictly their group. Because in most instances, remember, if you're a business owner and you have 100 employees and you want to provide healthcare to your employees, you have to go and negotiate with a healthcare company, with an insurance company to provide you for a package that you can provide to that 100 employees. So you're just negotiating on behalf of these 100 people. Now, when you're saying that you no longer have to do that, everybody has access to healthcare. So everybody has access to primary care. Nobody has to use the emergency room for primary care. All of these things actually not only save us a lot of money, but create a better social situation, period. So I would say there are businesses, there are a whole lot of businesses that have signed on in support of the bill. I believe that I saw Yu Ling here, who is part of the Campaign for New York Health, which I will certainly direct you to their website because there's a list of businesses that have actually joined and support these efforts. And so there's some business interests that do not like it, but for those folks that actually start thinking about it, it actually makes sense because we will have a healthier workforce. And if you want to provide healthcare to your employees, you don't have to anymore. It will be included just because you are a resident of the state of New York.
Thanks, Senator Rivera. So we have a few questions in the chat about choice. We always hear about that. That's kind of one of the big talking points against single payer, that you'll have less choice. And what you are saying is that this is one plan that they're all the doctors and hospitals are in the network. There's one
Right.
network. So
Correct.
one question in the chat though is it possible for doctors or hospitals to opt out? Can they refuse to be part of the plan, refuse to deliver services and be paid by it?
I don't know why they would. If we created a bill that says that anything that the New York Health Act provides would be banned to be provided by any other service, or any other insurance company, not insurance product, all of a sudden everybody would be, again, by the way, let's just talk for a second here, and I only have a few more minutes, but what we're trying to do here is we're trying to simplify. The single payer means that one entity pays the bills. That is all. The state does not control the healthcare that you get, as opposed to insurance companies, which, by the way, their job of the insurance company is not to provide you care, ladies and gentlemen. The job of an insurance company is to deny you as much as possible and provide you as little as possible so they can make some money. That we want to eliminate that. The state, because we're talking about an entity which is publicly, which is accountable to us, to the legislature, and to folks, and to the people, and in a much more transparent way, you will be able to know who the members of the board are. You will be able to see the decisions that they make, as opposed to the board of whatever insurance company covers you now, which again is in the business of denying you care, not providing you care. So I know I'm kind of like, I started rambling a little bit because I knew I only had a couple of minutes. Ping me again on the core of that question so I can finish it on that one. The core of that question, ask it again, please.
Cheryl, did you ask it?
Yes.
The quarterback question, sorry.
Can you re-ask the
The
question?
core of that question, meaning like this, because I kind of like rambled a little bit, I realize.
Doctors opt out.
No, I think you answered that well. I mean, maybe
Oh,
the
doctors
answer
opting
is,
out. Thank you. Doctors opting out. Doctors opting out. So again, we want to create one system. Why would anybody opt out of a system that pays better than Medicaid and actually would means that everybody who walks into your hospital or to your doctor's office, every one of them is going to pay you because the state is going to pay, as opposed to particularly, for example, every hospital that has an emergency room, every hospital that has people coming into it, like St. Barnabas, for example. St. Barnabas, most of the people that say there, that go there, as I said, this is in the Bronx, 90% of the folks who go there are Medicaid patients. Many of the folks who go there are uninsured because they're either undocumented or they don't have insurance. You will get paid for every one of those folks. Any type of safety net hospital around the state will tell you the issues that exist by the fact that they have to rely on pools of money to help them out with uncompensated care that on a yearly basis, the governor messes with, like we're fighting with him right now to make sure that some of those pools stay afloat. So there's no reason why anybody would opt out. And the choice question, I'm going to end on this. As far as the choice question, there's a guy, I've forgotten his name at his moment, but he was actually an insurance company lobbyist, right? A very high paid insurance lobbyist. And he was one of the people that came up with this message.
Wendell Potter.
Was that?
Wendell Potter.
Potter, that's correct. And he came up with it. He was one of the people that came up with it when he was still working for the insurance companies. The fact is that this issue of whether you have choice or not, you as an insured person right now, there's a lot of choices that you don't have. I mentioned this earlier. Insurance companies make decisions about which doctors are going to be in network or not. You have nothing to do with that. There might be somebody who you love, who your family has been going to for generations. Guess what? For whatever reason, and they don't have to tell you why, all of a sudden from today to tomorrow, that person's no longer on your network and you're going to have to find somebody else. Whatever medicine your doctor says you have to take, all of a sudden, hey, that's not covered and that's not in the formulary, so it's no longer covered. All of these things means that you have less choice as a person who is insured, because insurance companies, again, are not in the business of providing you care. They're in the business of denying you care. Bottom line, ladies and gentlemen, because I do have to go, but there's a lot of work to do to kind of educate folks on this issue. If you feel passionately about this, and I know that you do, this is why you're here. If you feel passionate about this, you need to talk to other folks about it, to connect other folks to it, and ask them, if you believe that healthcare is a human right, and that we have an obligation in the state of New York, as we do in the rest of the country, but in the state of New York, not only do we have the obligation, we have the ability and the opportunity to create a system which actually guarantees care to every single New Yorker. I believe we can do that. And with your help, we're going to push on my colleagues so that they get on board. Those who are already on board can actually be a little bit stronger on the thing. And I am hoping that we get to cross the finish line together. And with that, love all y'all.
Thank you so much for that. We're in
Deuces.
this,
Got to go.
get it passed.
Thank you,
Yes.
Senator.
Thank
Appreciate
you,
it.
folks. See you soon.
Thank you.
Thank you.
Okay.
Take care. Well, that was like speed Q&A, but we didn't get through nearly all of them. So we're going to do our best to capture these questions and find a way to get answers for you, so they won't be lost. But I hope we got some of the key, most burning questions answered in that session. Please don't forget to go into the Google Doc that was dropped in the chat and sign up for action. We need to get this passed. We're going to switch a little bit of gears right now and talk about a benefit of the New York Health Act that is a little bit hidden. And we want to bring this out tonight because we think it's so important. All of the hidden costs in local government budgets and school budgets to providing health coverage to public servants, teachers, retirees. So we're paying not only for our own health coverage too much, but we're also paying, again, through our taxes. So we want to see what the impact would be on these budgets and the potential savings if the New York Health Act were able to pass. And so we have a small panel here, and I'm going to pass it to Steve to start posing the first questions to Darius.
So first of all, I'd like to reintroduce Darius. He's the Albany City Treasurer. He spends his days doing math for us. One of the hidden costs of our current health system is the cost of our local governments of private insurance coverage for teachers, government officials, retirees, and then the local share of Medicare costs, which land on our counties in large part. All of this adds up to millions of dollars of costs to local governments that would be eliminated or reduced under the New York Health Act. So as a treasurer of the city of Albany, you analyzed what the impact of the New York Health Act would be on the city's finances. I'm just curious, what did you find? I know what I found.
Wow, we'd save a lot of money if we had the New York Health Act. It really is that simple. I'm really glad Senator Rivera. We're both alums of Gillibrand's office. Myself when she was in Congress, and him when she was a senator. And we talked about this issue a lot on the national level when we were working there. But we really, when I became city treasurer in the city of Albany, which makes me the tax collector and the chief financial officer of the city, I took a look at it on a very granular level. And how do the savings that will run throughout the system with the New York Health Act, the way that Senator Rivera was talking about, which I'm very glad to hear that he was actively talking about the cost savings, because it's not often what we talk about in advocacy for a single payer for the New York Health Act. I calculated in the city of Albany that if the New York Health Act came tomorrow, we'd save about 30% off our property tax bills. And that's assuming all the added costs to the municipality from having the New York Health Act, and also assuming that we would put a portion of that of the funding back into the city for what have you. We still would be able to save about 30% off our property taxes, which is a huge amount. It would be the single greatest tax cut in the history of New York State if we were able to do that. And the reason why single payer healthcare and the New York Health Act will be able to do that is because we spend so much money in our municipalities for healthcare. It is almost half of the entire amount we tax. It's called the tax levy. All of our properties in the city, all of them, almost half of it goes just to paying healthcare for our employees and our retirees. And I want to make one point here on retiree healthcare, because I saw some comments here about how people who are teachers have lifetime healthcare because they were public teachers. Don't count on it, because in the city of Albany, we do provide our retirees with healthcare, but we are not contractually obligated to do so, and we are not legally required to do so. And I would surmise that a lot of other municipalities are the same. So be cautious about thinking that we have healthcare based on what's public employment right now. You may not. But getting back to the larger point, between the employee healthcare and retiree healthcare that we spend in the city of Albany, that we spend in our school district, that we spend in our county government, and you add in the amount of the Medicaid share that all counties have in New York State. New York counties, they handle themselves. But all counties in New York State have a Medicaid share that they have to put in. So for Albany County, where I live, between the costs of the healthcare for employees and the cost of the Medicaid share, it's actually more than our entire tax levy. We could actually eliminate our county tax entirely if we had New York Health Act. And this is you know, it's true. It varies municipality to municipality in New York State, but it's true in all the areas that we would see savings. But it's also true, as Senator Rivera talked about, it's true in business, and business is coming to realize this too. That I've seen stats where the cost of healthcare, if you want to go out and buy a new car, the cost of healthcare on that vehicle is anywhere between $2,000 to $4,000. That's what we're paying. It's a hidden tax. Healthcare, our healthcare so-called system in this country is a hidden tax on property taxpayers and on virtually everything we buy, because it's how the amount of money that we spend, which is about, I think, 18% now of our gross domestic product. $1 in $6 we spend in America goes to healthcare. That filters down through our entire economic system in a way that really drags it all down. And Senator Rivera talked about this. I love the fact that he talked about this from a economic standpoint. What that does, it takes capital that's allocated to unproductive resources, unproductive places, profit, advertising dollars for healthcare, and bureaucratic costs in trying to deny healthcare. It takes it out of that and puts it into productive capitalistic uses. Now, I know that when you're talking about so-called socialized medicine, the glorious capitalistic effects that it will have is not what we often think of, but that's exactly what's going to happen. We will see billions of dollars in New York State immediately go into more productive uses, like making profit for companies. And that is something that businesses are starting to realize. That's something doctors are starting to realize. I come from a family of doctors who are usually loath to have more government, intervention with their with medicine and with their practices, but they can't deal with the insurance companies anymore either. You think about the drag that it has in municipalities for what it costs us to pay for healthcare for our employees. It is an enormous cost drag for medical facilities dealing with multiple insurance companies, battling with them all the time. They have to have an entire separate bureaucracy just for that, just to deal with the health insurance companies. And the New York Healthcare Act eliminates most of that. And that's not to mention, from a business standpoint, the cost for your providing healthcare to your own employees and how that is all over the place year to year. Now, this year, we're probably going to see a reduction in our health insurance costs to municipalities and to employers, but that's because no one provided healthcare for anybody for the second quarter of this year because of COVID. So the money that should have gone to healthcare is now going to go back to lowering rates for a year before they jack up again. Now, as everybody gets caught up on the payments for their health issues. So the bottom line of the research that I've done in the city, and done for other municipalities around the state, and the Campaign for New York Health also has terrific resources on it, particularly at the county level. This saves a lot of money, and we're talking about how it filters down, not just at the 30,000 foot level, where healthcare in this country, if we pass single payer at the national level, we would save $400 billion a year. Okay, that's great, but it doesn't really connect. But I can legitimately say to somebody in the city of Albany that if you have a house that's worth $150,000, you can save $2,100 a year on your property taxes if we have new single payer healthcare tomorrow. That's how much this is. And when we talk about single payer healthcare, and Senator Rivera said, talk about it in terms of a human right, and if you think it should be a human right, then we need to fight for it, which is great. And I think I certainly agree with that. And most of us here tonight agree with that. That's great. But make sure to include that it is going to save us a lot of money, because just figure out how much money that you're spending in your municipality and your businesses on healthcare, and take that out, add in what the additional tax would be for the New York Health Act tax, and that delta, which you see on the screen right now, that shows you the money that you can save. You can see, yeah, we did. I want to thank Cheryl for putting that together today. This is our the first attempt, the first time I've had actual PowerPoint graphics for me to show it, but you can see it quite clearly just how much we spend on healthcare that we won't have to if we have the New York Health Act. So I've gone on a while.
No, that's fine. When, so when I ran one of the tax proposals against Suffolk County's budget, I mean, I found that first of all, $230 million comes off just because they don't have to cover Medicaid costs anymore. And then I found that their healthcare tax would drop down, I think, from 350 million, their healthcare payment that they're paying right now for insurance would drop down to 100 and some odd million based on their current payroll. I ran numbers on the Huntington Union Free School District and found that they're paying $22 million for dental and healthcare for their current teachers. Unlike you, I can't even figure out how much they pay for retiree benefits, because that wasn't clearly specified. But that same tax proposal, when I ran it on their, on their payroll, $5.5 million. I mean, they're saving over 15 million bucks that they would just have to spend on books or a new baseball field or whatever Huntington Union Free School District needs. Like every time I do this, I just fall over at the numbers.
Yeah, I was when I first started looking at it in this way, I was both astonished and not surprised in any way, shape, manner, or form. Because it is how much we spend on it.
I remember the first time I saw these numbers from you 4 or 5 years ago, I actually had to call you up and ask you, is this really what it is?
Yeah,
these numbers are real. And if I could just jump in, I mean, I think what the other side of this that we want to look at is if we don't do something about this. This is a trajectory that these costs only grow and grow and grow. And we know that for the first time this year, Suffolk County is asking the employees of the county to contribute to their health coverage. And the coverage will only erode from there if something isn't done about that. And getting back to the issue of what you think you're guaranteed as a union member and choice, we've asked Sigrid, who is a retired teacher and part of our group, to share her experience, what you think you're getting if this isn't brought under control, where things are going. Sigrid, over to you.
Yes. My name is Sigrid Meinel, and I taught on Long Island. I'm a retired public school teacher, and I have an excellent health care plan today. Over the years, my school has sought to maintain a high quality plan, and they've changed providers a number of times in order to do that. I retired 11 years ago, and up until my retirement, our union, NYHA, was successful in keeping full and free health care coverage for our members. Subsequent negotiations after my departure included a 5%, then a 10%, then a 15% contribution to healthcare costs by teachers. Negotiations since that time have centered on healthcare contribution, forfeiting other issues like wages and working conditions. Retirees have been protected from this contribution so far. A year and a half ago, retirees were called into a meeting with our healthcare administrators and told that we were going to have a new provider due to costs. In addition, we retirees would move from Medicare to Medicare Advantage. A number of informational meetings were offered to explain what Medicare Advantage was, and that our services would be the same as with Medicare. Our doctors would be the same, our policy would be the same for now. We could not opt out and stay with Medicare. We were not given that choice. We would be out if we refused to make that move. We would be on our own. We would have to shop around for a supplementary health insurance besides Medicare and have to cover that ourselves. There's a great push to move people from Medicare to Medicare Advantage. Commercials are bombarding the airways, I'm sure you've seen some of them, telling Medicare recipients that they should and can receive from Medicare by calling a telephone number and asking for hearing aids, dental services, eyeglasses, and home health aids. This number puts them in touch with Medicare Advantage, but also with a private insurance broker. Recruitment to privatize Medicare is the agenda. It's true today that my Medicare Advantage, that with my Medicare Advantage, I can use my doctors and my medicine is the same at no extra cost today. My sister and brother have Medicare Advantage as individuals. They're not teachers. They pay copays and monthly fees. They must use doctors within the Medicare Advantage group, and their directories have been called out for being inaccurate. Both siblings have neglected treatments because of copays. Commercial insurance wants to avoid those needing health care and ensure they're healthy. Their incentive is to avoid risk. They're obliged to their shareholders first. They can delay and deny services. They're constantly changing products and services, and they offer as well that they offer, and also they constantly change cost sharing obligations. Ralph Nader referred to them as Medicare disadvantage and a corporate trap. It's just a matter of time before Medicare Advantage will change teacher retiree and enforce copays and fees and limit choice of doctors and deny and delay certain kinds of services. Some union officials feel that the private insurers can coexist with some kind of public plan. In that way, the power to negotiate health coverage is leverage for the union. They say that employers and unions together can continue to innovate healthcare and that the marketplace is necessary for innovation. Private insurers are not interested in innovation. A final argument that some union leaders is to remind union members that they've negotiated concessions all along for good health care. Why would we want to give them up, they ask? Well, I say we are not going to allow good health care plans to disappear. With the New York Health Act, those of us with good plans will get the same plans and even a little bit better. Those who have no health care or inadequate coverage, they will get complete coverage. Now, I see them as my brothers and sisters. We all deserve good coverage. Healthcare is a human right. We will save money through a single payer, and the money our schools save by not purchasing private employee insurance can be redirected to improve the education and the general welfare of our students. Thanks.
Thank you so much, Sigrid. That was really powerful. And you made so many points that we need to take on board. I think this idea that anyone has a guarantee from their employer-based coverage or their union or their, whatever's been promised, when costs are exploding as they are, there is nothing guaranteed. And I think that's something that we need to really face. And we are seeing it already. We're seeing these cracks already. And the private insurers through Medicare Advantage are jumping right in, and they're trying to blow that door open. And then it's going to be very difficult to put that genie back in the bottle. So thank you so much for sharing that. And
Sure.
Sorry, did someone jump in? Just one final point in the session before we open it up for questions is turning it back to Darius. I know you've done some thinking about tools that you could share with municipalities so they could do their own analysis of their own budget. And so I'm going to turn it over to you to share a little bit of that in case someone wants to go home and try it on their own budget.
Yeah, thank you for putting it together for me too. Let me just scroll down. Are you gonna put it on the screen? There we go. It's actually, the calculation is actually fairly simple. You go and look at how much your municipality is spending on healthcare, and then for the city of Albany, it was 28 million a couple of years ago, and then you subtract from that the increased cost of whatever the payroll tax will be. I've used a 6.25%. It may be a little bit higher, but I have to see what that is. For Albany, that was 4.5 million. And then you essentially subtract that number from the amount of money that you're spending already, and that gives you the amount of money that's available for savings. Steve's chart shows that quite clearly as well. And this is really also just something to be aware of if you're going to take a look at a budget. There's a direct payments that your municipality is making for healthcare, for health insurance, and for retiree insurance. But there's also all these additional costs that are really hard to kind of calculate. You know, like what does it cost a municipality to have, you know, an entire staff of people dealing with health insurance claims and dealing with the health insurance companies to the extent that they are? What does it cost for the health costs, the healthcare costs for workers' comp? It's not that easy to ferret those figures out. Make sure you include dental, make sure you include anything else that is paid for, vision, those things that are paid for. And that really, that shows you what the money is that's available there for you to reallocate. Either, you know, as a tax collector, my favorite is at least some of it should go to tax cuts, because frankly, our tax burden in New York State on property taxes is enormous compared to other states for a whole host of reasons. But also, I don't know a single municipality anywhere that doesn't have projects that it wants to finish, repairs that it wants to do, roads that it wants to fix, potholes it wants to fix. You can see on my chart here, you know, for Albany County, you know, the reduction from 116 million, which includes the county Medicaid share of the employee costs of healthcare, 5.7 million, that gets you to about $110 million in savings that are available. And in the county of Albany, the entire tax levy that we charge all the buildings, all the property in Albany County is $92 million. So all of a sudden you have, you know, you come out so far ahead that there's all this money that's available for tax cuts and for other projects and other things to do. And Medicaid is administered through our counties. And that is an enormous bureaucracy, a Medicaid bureaucracy, county by county, that is essentially, most would be reallocated to elsewhere. To, you know, they'd have to find other jobs, which would be, I think, that there's a bridge part of this program to get people trained and placed into new positions. But we would have a different healthcare bureaucracy that would be slimmer and more efficient, and then that they would hopefully be able to find places in that. One key statistic I think that people should be aware of, that we talk about a lot, is the administrative cost of healthcare in a country. You know, we already, one of the ironies of all this for me is when you have people talking about how we don't want government, you know, healthcare, we don't want the government, you know, taking charge of our healthcare. Well, almost 2/3 of our healthcare already is government controlled through Medicaid and Medicare. And we, you know, when we get older, we were talking about long-term care earlier. When we get older, what we end up having to do is essentially dispossess ourselves of the wealth that we created and earned all our lives, just so we can get on Medicaid, so Medicaid will pay for our long-term care in a facility. That's another thing, another part of this that New York Health Act and single payer would eliminate. But the amount of bureaucracy that goes in, and this is true for municipalities that I just explained with county and the county Medicaid share, but also for businesses as well. The amount of money and time that they put into that can be reallocated elsewhere, because those costs simply wouldn't be there for them anymore, and to be replaced by a charge in some higher payroll taxes.
Thanks, Darius. I think this really hits home, and we are answering the question, how is this too good to be true? It's not too good to be true, because we have so much money in the system that's not being used well. We have the 18% that's going to private insurers for profits, marketing, administrative costs. We have these billions of dollars in our local budgets, the municipalities who are paying for private coverage, overpaying for private coverage. And when we put all that money into the pot, we can provide more for everyone.
We have to liberate ourselves from a mindset that links our healthcare to our employment, to say that, oh, this sounds too good to be true. This can't possibly be true. 32 of 33 industrialized nations have figured this out. We're the one that hasn't. It's ridiculous, if you ask me. And you know, the cost savings, they're real. This is one aspect of it that we're going to see, but you'd see it throughout the entire economy. And big business really actually knows this. which is why they're happy to move like car manufacturing facilities to Mexico and Canada, where their healthcare costs are controlled, and they don't have to deal with it the way they do in our country. So, just more things, more food for thought, I think, from me.
No, completely agree. I think every business, I think every municipality, and me personally, I would certainly like to have an idea what my healthcare is going to cost me next year.
The one thing business really truly hates is uncontrolled costs.
Mhm.
And healthcare is usually their biggest uncontrolled cost, 10-20% per year. And it has over the past few years. Obamacare is the only thing that's actually brought it somewhat under reasonable control over the last few years, because it spread the risk to a larger insurance pool. This is the way, and incidentally, that's one of the reasons why, New York is uniquely situated to transition to single payer healthcare easier than other places, because we have a large insurance pool here. It was more difficult for Vermont because they have a smaller insurance pool, and then people got cold feet and they pulled out of it at that point in time. But I would also expect to see down the road, I think we'll be the first domino, quite frankly. I would expect to see other states, but particularly neighboring states, try to then buy into our system of doing things and gradually expanding the insurance pool that way. If we don't have a complete turnover in Congress that says, hey, we want single payer healthcare for everybody, which I also don't think is out of the question, because the people who are knee-jerk reflexive against socialized medicine and single payer healthcare are not quite the people who are in Congress anymore.
Right.
I don't really want to bring politics so much to the equation here, but Trump populism is not exactly the old school Romney populism, even though Romney was responsible for Romneycare in Massachusetts. But it's not the same as the old time, I guess I'd say, William Buckley conservatism that just wanted government to not do anything. It changed a little bit.
Let's switch to some Q&A. Sorry, Steve, you had a question?
No, I had a comment. Go ahead with the question. Q&A is better.
I think we're going to switch to Q&A, so please drop any questions that you have in the chat around this particular issue and the calculations and the impact. One question that was in the chat, Darius, I think we've heard a lot about, some taxes will go down, up, down. And what do you think is the net impact on people's taxes in New York? That's one of the questions in the chat.
I would say, generally speaking, if you take into account costs and taxes, generally speaking, if you are employed, you own your home, and you make under probably $150,000, you're going to come out ahead. There's almost no scenario that I can see where you don't come out ahead, because you are now getting rid of, you will get rid of a chunk of your property taxes. You will get rid of all your deductibles, co-pays, all the costs that your employers have been forced to shove down on us as employees over the past 30 years or so. Those are going to be gone. So you factor all that in with an increase into of your income tax. It's difficult to say because it's not quite hashed out yet, I think, at the state, whether or not it's going, what the actual rates are going to be, or is that going to be supplemented from someplace else? I would actually suggest including the stock transfer tax, which we actually charge on stock transactions, but we charge it we charge on the transaction, take it into the state, and then refund it back to the people who were charged it for reasons I'm not really quite sure, but that's about $17 billion right there. So those are, with the stock market and with New York as still a center of business, I think that's why we're uniquely situated. It's going to be different for everybody. It's going to depend, from a property tax standpoint, it's more beneficial in the cities than it is in the suburbs, because we have larger forces of firefighters and police and road crews in our cities. But something also to keep in mind: the more valuable your property is, the more you're liable to save on property taxes, and the more that you pay out of pocket right now for your health care, the more you're going to save with single payer health care.
Thanks for that, Darius. And I think we get this question all the time, and it's just that evil word taxes. But what you're showing here is all the money that we're paying into our system for our healthcare, plus money we're paying through our taxes to cover healthcare for public servants. That would be offset, so that we're not talking about any new money in the system, but we would have stability. So we would have predictability, which we don't have now. There are no surprise bills, no surprise cost increases in the coming years.
And why would I not pay $8,000, for example, to get $10,000 back? No one, that is a net positive for anybody. Are we going to say no just because that $8,000 is a tax, is called a tax? No, no sane person would do that. And that's what we have. That's the way we have to start thinking about this from a cost standpoint.
So I'm trying to see if there are any other questions in the chat. I might have missed a few. So if you want to drop it in again or to pipe
I'm
up.
trying to think if I haven't, I'm trying to think if I haven't covered some of the topics that people sent in at the beginning of the program. I believe the act would cover medications. Is that correct, Steve?
Yeah. Let me just
Yeah.
hop in there. And I know Tina had a question in the chat, and maybe if she could drop it back in the chat, that would be great. And while she's doing that, I just want to actually bring up a statistic that the Campaign for New York Health has put out. As of October of this past year, over almost 750,000 New Yorkers lost their job that provided health insurance. And those plans covered another 600,000 plus family members. So that resulted in over 1 million New Yorkers who are suddenly without health care coverage because of the pandemic. So just, again, getting to the point that Darius was making about, it's insane really to couple employment with health insurance. Thanks.
A couple things. I saw a question from somebody about New York City. I haven't taken a hard look at New York City because I'm not quite sure on some of the numbers there, but it still is. It clearly would be somewhere in the neighborhood of 40% of their tax levy goes to healthcare. I think it's actually higher than that, but I haven't had a chance to really get into New York City too much. I think someone talked about long-term care. Long-term care was not originally included. I think in the New York Health Act, or it might have been not included in HR 676, which is the legislation at the national level. When with long-term care included, what that essentially would mean. Yeah, go ahead.
Long-term care is included from day one
Right.
now. That's the change.
Long-term care, the term long-term care is for nursing home care. For those who don't know, or haven't been forced to think about it yet, you better be able to pay for your long-term care in a facility, which can be very expensive, up to $5,000 a month and sometimes even more. Because if you don't have a way of paying that, either through whatever insurance you bought prior, whatever you have are able to pay for right now with the money that you have, if you're not working anymore and you have passive income from stocks and business ownership, something like that, to pay for your long-term care, you're all set. If you're not, then you have to get rid of all your assets that you've built up your entire lifetime. So your all the wealth that you've earned, you got to start passing it down to your kids if you have them. You got to start giving it away, do something, spend it down. They'll let you keep your house for a while, but it eventually goes over to the facility, essentially, that paid for your long-term care, so that you can get onto Medicaid, which pays for long-term care. So the funny thing about this, the more you get into single-payer healthcare, it'd be an enormous tax cut. It's an enormous reallocation of productive wealth. It's going to be an enormous shift of money from uses that it just doesn't do anything to productive uses. It's the largest transfer of wealth from useless corporate bureaucracy to actual taxpayers.
So
We had a couple of questions here. I'm sorry, Steve, I jumped in again.
no, you go ahead, Cheryl. You got them.
Okay, just a couple of questions related to, I think, this idea of New York being a state and doing this first, right? And with the rest of the country not going along. So the first one is about portability. What if I leave New York State? What if I've paid my taxes and now I want to go and either spend some time somewhere else in another state or to retire there? What happens to that? And then how does this align with the federal programs that might, it will still be going on, obviously, if we don't have national single payer? And I'm going to leave it to Steve and Darius both to jump in on those.
Steve can handle.
Sorry, I didn't quite hear the question. I was typing.
How does it affect portability, and how does it affect what we have right now at the national level, Medicare, Medicaid, and Obamacare?
Well, basically, I mean, it's hard to say, like the funding from the federal government would still come to New York State, so we wouldn't lose a penny of that, which is one of the reasons this works so well. If Medicare for all, for example, were to be passed, we would just be prepared to deliver it because it would most likely be passed through the states. And it would just make that transition sooner and easier. You know, we would already be there.
But, go ahead.
Right, that was basically it. Was there part
My
of the
understanding
question?
is that it requires an agreement by the federal government for the federal dollars that are spent on medical care in New York State to do it. We have.
No, it doesn't. It just makes
Okay.
it makes it more efficient if they make it easy for us,
Okay.
but we can do it anyway.
Okay. That's good to know.
I think we have a question for the other Steve, Dr. Steve Auerbach. There's a question here about what this would mean for physicians. Is there any indication that this would be attractive and would actually attract physicians to New York State, or do we have to worry that it would have the opposite effect? I don't know if you're still here.
So like lots of other sectors in the economy, there's been lots of fear mongering around doctors and to doctors and about doctors. First of all, the majority of physicians nationwide now support single payer. There's two studies that I usually refer folks to on this. One is academic peer review study, and another is actually by Merritt Hawkins, the HR company, whatever outsourcing, whatever they do. And they both have shown, first of all, a steady increase in the percentage of physicians that support it, as well as roughly about 60% as of a couple of years ago, and with an upward trajectory. There is a differential in support by specialty and by region, as you might expect. The issue of Canada is often brought up. There is now a net flow of doctors from the United States to Canada, not the other way around. Number one. Number two, there is a net flow back to Canada of Canadian physicians who moved here and are now going back. So both American physicians on net, overall net travel in that direction, as well as returnees, both. Frankly, as there are several studies that show that many specialties, mostly in the primary care fields, would actually have an increase in their income under single payer. It is likely that the very, very highest paid subspecialists, those that do a lot of surgery or interventional work, interventional radiology, neurosurgery, those sorts of folks, would probably take somewhere around a 10% hit, is the unofficial estimate, in their income. The flip side is that lifestyle would be a lot better for everybody. Roughly, I'm sure if you've spoken to any of your doctor friends or physicians, they can tell you about how laborious dealing with modern electronic health records are. There is a brilliant study that shows, using the exact same electronic health record company's product called Epic, which is kind of the mainstay that I'm aware of amongst the practitioners that I'm aware of in the hospitals and doctors I work with. In other countries that use the Epic product, but have some form of national health insurance, single payer type situation, the number of keystrokes that they do to type a note is cut by 2/3. Basically, 2/3 of our charting is managing insurance companies. The problem is that the doctors right now, in addition to taking care of the patients, have to also spend a lot of money and time and effort managing the insurance companies. So there's a lot of myths out there, both about doctors and also about hospitals. And we would argue that, in fact, single payer would be good for both hospitals and doctors. There's a lot of sort of Trumpian level projection by the critique of, oh, if we have single payer, the hospitals will close. No, it's under the current system that the hospitals are in financial difficulties and closing. And COVID has really, I like to say that COVID really hasn't created anything new, but COVID has further worsened, but also simply further exposed, if you will, the pre-existing conditions of our bad healthcare system. So for example, the very idea that somehow or other hospital reimbursement, to say nothing of this, that hospital reimbursement should be based on a sort of per patient, per procedure basis, and that therefore hospitals have an incentive to figure out which of their procedures, which of their categories of care has the highest profitability and push for that. Is just insane. So at least in New York, we've had hospitals threaten to be closed or shifted to have their beds doing, let's say, psych beds, which there's a shortage of, to orthopedic or OBGYN beds, which are higher profit making, that have had to be resisted. And then we have the situation with COVID, where the hospitals are flooded with patients, huge numbers of patients, way over standard census of patients to be taken care of. And yet, because the reimbursements aren't good, it hurts them financially to do that, while they're losing all of the so-called elective care, which bills at a higher rate. So none of this makes any sense. The way we finance healthcare is very good for the health insurance companies and not very good for either the doctors or the hospitals. Let me just close by saying that doctors in all of the other Western developed capitalist democracy countries all make a very nice income, thank you very much, and they will continue to do just fine here in the United States, but with greater professional autonomy and less bureaucratic overhead.
Thank you so much for that. And just 2 points that I can't emphasize enough. I think one is we talk too much about who's going to pay more, who's going to pay less, who's going to get more, who's going to get less. There are so many other factors, that the psychological stress of using our system, the burden on healthcare providers to do paperwork instead of providing care and thinking things will get denied. I think that we don't talk enough about those hidden costs in our system, to the psychological costs too. And the other thing is this idea that you're paying for only services delivered, that the money that we pay into our health system for our premiums, it should be a public asset that can be moved around as needed.
Yeah.
And right, and this is what they did in other countries when COVID hit. In our case, the money ended up in the profit lines of the private insurers.
Right. So the insurance companies have all made massive killing, and I use that word literally and figuratively. Their Wall Street valuations have all gone up. They've all reported record-making profits during COVID. Meanwhile, most Americans are, shall we say, not making profits during the pandemic. And, you know, it's interesting. We talk about all these wonky studies. And by the way, if anybody is out there that wants sort of a healthcare providers oriented presentation, please contact me. That's sort of what I do is go to doctors, hospitals, residency programs, etc. And CME and ACGME credit is available. But there's several studies, including even by the far right wing Mercatus Institute, funded by the Koch brothers, Boo and Hiss, but also by Urban Institute, a center left group that does not support single payer, and others, all of which show that on net, if we shift to single payer compared to the current system, on net, a higher percentage of the dollars and a higher total amount of the dollars goes to the hospitals, and a higher percentage and a higher amount goes to the doctors. So by eliminating the middlemen of the insurance companies and all of the overhead associated with that, as well as some of the cost savings on drug prices, in fact, the doctors and the hospitals net come out ahead, as does everyone else who now has guaranteed health care regardless of change in employment, change in life circumstances. You know, it's that guaranteed portability, as well as the comprehensive coverage, as well as the one big network, everybody is in the same network. That seems to me to be the selling point for the general public. Oh, and progressive taxation, cheaper, higher income for 95% of people. And I'll stop there.
Thank you so much. I think we're going to close the session. I really want to thank Darius and Steve for the analysis, Sigrid for your powerful story of your experience, Steve Auerbach for sharing this perspective from the healthcare providers. It's been a really great session, and I hope it's convinced everyone that this is not too good to be true. that we need to have the New York Health Act, and we can have it. There is no reason not to, except that some people are standing in the way who are benefiting from our current chaotic and inhumane system. With that, I'm going to pass it to Catherine to get us just revved up for action. What can we do next to make sure that this gets passed? But thank you to everyone who contributed in the session.
Great, great. Hey, thank you, Cheryl, and thank you, everybody. Really wonderful and a lot of good, useful information. I want to encourage everybody to save the chat. You can do that by clicking the 3 dots in the lower right-hand portion of the screen where you have the place where you enter in information into the chat. I want to let everyone know that this is being recorded, and after it's uploaded to Peer's YouTube channel, everyone who signed up to participate tonight will get an email with a link that you can share with people. A lot of folks have asked about that in the chat. So what we're going to do right now is we're going to go into breakout groups, and we're going to have people, we're going to tell people about 3 different areas that they can actually activate and get involved in right now. Those 3 areas are, number 1, to help in raising general awareness about the bill. Number 2, outreach to organizations that may need to learn about it or that may be skeptical about it. And number 3, outreach to legislators by phoning them, by texting them, and other ways. So we're going to go into breakout groups. But let me just say this, if there are people here, because I know some people from representing municipalities may be here, they may want to dive deeper into the finances. And so you can stay in the general room and not go into a breakout group by just ignoring the invitation to join the breakout group. Darius is going to stay here and he will answer those questions. And maybe I'll also say that initially, if Dr. Steve could maybe stay in the group so we could get the people that might want finance and also information about doctors and hospitals. So does that make sense? And what you're going to, for those of after the breakout groups, we're going to just the meeting, we're not going to come back again. So this is sort of the official end of the meeting. And I just want to really thank our partners at LIA, everyone on Peer, and everybody who made this a particularly important event for helping us forward with the New York Health Act. I believe the week of March 1st is the week of action. So stay tuned. We're going to need to have everybody on board for that. So I'm going to create the breakout groups right now, and you'll get an invitation to join. Please accept that, and we'll get to work.
Thank you.